Greg Doucette's question in collaborative with More Plates, More Dates, Derek, getting the most out of HRT. So Greg is obviously a known anabolic steroid user, that he's now more conservative. He's on HRT, testosterone replacement, and he's asking the other YouTuber, Derek, who's obviously an expert himself, bro science guy in androgens for sure. And Greg wants to live to 100, but he wants to get the most out of his HRT, and it appears like it's mainly for a little more muscle mass. So let's get right into what these guys talked about here. Let me break it down scientifically, because they did a great job. They stayed away from the medical recommendations. They talked about just the science of the testing and the sexually binding globulin and all these things and the numbers, and they talked about adding other androgens and PEDs. So let's break it down. I want to break it down for you guys. Right off the bat, Greg is on 120 milligrams of, I assume, cypionate or nanthate per week, and his numbers are 700 total. But then right away, Derek went into the details that his sexually binding globulin levels, the carrier, if you will, for the testosterone, is going to be low, and therefore there's a disparity between the total and the free. So this is very common, guys, right? So this is you see this in laboratory medicine with testosterone all the time. I'd say 95% of men, once they're chronically on TRT, not just oral Anavar or Winstrol or steroids, which push down the sexually binding globulin and sets up a disparity between the total will be lower, because the binding globulin, what's circulating around the blood and which measured on total testosterone in nanograms per deciliter, is going to be lower compared to the free testosterone. Let's explain it physiologically, scientifically. You're injecting the ester into your body, into the deltoid, into the glute or the leg, anywhere actually, intermuscular injections or sub-Q. Really sets up a little difference, but it's still the same. Your circulating androgen is all exogenous. Your endogenous androgen for your testicles is negligible. A lot of people, I don't think, know that. Unless you're on HCG or Clomid, which that's apart from this, and they didn't go into that, so it makes it pretty simple for this discussion. So Greg stated that his testosterone total is 700, and his free was over the upper limit normal. Now, I have my labs here. Hey guys, what's going on? This is a very cool video. It's about the details of labs, right? Testosterone total and free, sex hormone binding globulin. For all you men that are on testosterone, self-administered anabolic steroid users in the world, and for men that are even under doctor's care, you want to understand your labs. Guys, it's so important. I know you're into this. So I cut a deal with private MD labs, 15% off just for you guys. Use the promo code AnabolicDoc15. Check it out right here and get in there, guys, and get into your health. And thank you so much for trusting me, man. Keep you guys strong and healthy. Boom. I have my labs here, and I checked mine a few months ago, and mine's 740, right? So this is the nadir. It's the day of the injection that we don't take the injection and we just check to see where it is. There's going to be always an up and down dynamic of intermuscular injections. We try to keep it so it doesn't do this crazy stuff. Giving testosterone injections every 2 weeks or a month obviously is going to be wrong, so you want to do it every week or last maybe twice a week, right? And I'm on about 100. I'm about 100 every 5 days, and Greg said he's on 120, so you see it's very similar. Now, my free testosterone is 165. This is picograms per mil. The reference range goes 35 to 155. Boom. Greg said that his was a little bit higher, I believe. So very similar. So when you are injecting testosterone esters, 90% of men or more, after a time, we're going to set up this cycle where you're going to see lower testosterone total versus free. So what does it set up? And I agree with Derek. It's chronically increased androgenic signaling, because the free is super physiologic, and that's what's affecting your brain, your whole body, every cell in the body. Remember, this is a lipophilic issue, right? So the phospholipid bilayer, the biologic bilayer, is going to be readily accessible to the androgen, right? So it's fatty. So it's going to get into every cell, from the hair follicles to the skin, the brain, right? The heart, the nipples, gynecomastia, endothelial circulation all around the body, testicles and prostate. This is all the big money stuff. So they talked about that chronic androgenic signaling because of the increase effects. Now he's on TRT, so that's always going to be there. When you look at this with men, you'll see that the total's basically circulating and it's useless. What's the free? Now that goes for diagnosing men that are natural and natty, and they're getting a new diagnosis for TRT for all you guys that are interested, that are not on androgens. And then once you're on the androgen, you're going to see this. Now it's amazing that it sets up this lower sexually binding globulin level, and you just live that way. And therefore your free testosterones are very easily high, maybe too high. And then of course you get conversion to estrogen, and you get the effects across what Derek said is the heart in the brain, which is great. Derek, you did a great job on this. You're getting across the information and the word that keeping the lowest effective dose. So let's talk about that. Then Derek went into, Greg, you should keep your lowest effective dose across your body because of the health effects. But of course, he wants to bump up and get some more muscle. So these guys kind of went back and forth on this, and then they talked about baseline TRT, keeping that androgen level low, and then adding steroids. And they talked briefly about Anavar, and Proviron, and they related that it drags and it drives down sexually binding globulin more, and that some anti-aging places actually use that in addition to TRT to keep the sexually binding globulin low, therefore setting up that free level being higher. And again, you have to then ask the man, how much risk does he have and how does he feel? This is a great point. You guys did a great job. Then they talked about growth factors and adding some growth hormone. Again, this is Greg's whole concept here was to maintain, I think he wants like another 5 pounds of muscle. And Greg's a professional bodybuilder, an incredible power lifter, so he's already built tons of muscle. He's trying to maintain I think Greg's in his 40s. He looks great. He just wants to keep his heart and his prostate and his health great. This is going to be what it's all about. This is what I do every day for patients. So they talked about a little bit of insulin, and they talked about growth factors and growth hormones. And they didn't say anything inappropriate. They just said that if you want to keep your doses low on everything, can it be synergistic, like adding a little bit of growth hormone to a low dose of TRT, and then other drugs, keeping everything to a down low? Derek, you did a great job on that, because the collective forces, he said vector forces, and this is what it is. All these different vector forces on your heart, your prostate, your brain. Again, forget the skin and the gynecomastia as long as you don't get breast cancer, which I've never seen, thank God, is that in the end, the rate limiting steps are going to be on the blood pressure, the cholesterol, the heart, the prostate. Come on, guys. This is 100% true. Everyone knows it. Once you're on TRT, at a certain point, you're never coming off, so it's going to be this chronic state. You want to keep those vector forces down low, but you want to feel great, and of course, who doesn't want to be big and strong? Even me. Now, the last part I want to go into here is, for me, is from my perspective, is putting it all together as a physician. And Derek said, you should find a physician who is not judgmental and is going to work with you on this. Again, kudos to that. And you could see with my work that we're doing academically that there are young physicians that are out there in America, and I assume Canada, all over the world, that are more progressive on this and understanding, not giving a blessing to steroids, but just understanding that men can do great on TRT and that men are going to use steroids, and we need to help them so they don't suffer. It's called harm reduction. So with that said, lowest effective dose of the testosterone is absolutely the money. That's exactly it. Derek is right on that. Greg received it, and Greg hears it. And what are the doses looking like? They're like, if you're looking at 200 milligrams per milliliter, which is cypionate and nanthate, again, this is common stuff. Sustanon 250 is 250, so it's a little bit more. 0.35 milliliters to 0.5 every 3 to 5 days. That's the dose, guys. That's what Greg's on, something like this. And that's what I assume Derek is on, and all these different guys trying to keep it to a down low. Now, It's interesting they didn't discuss ancillary medicines like aromatase inhibitors, which is interesting because those can be very toxic and men can use them, but in the end, this not adding that for some benefit to the TRT, which was very interesting. Most other anti-aging doctors, even years ago or today, would start talking about blocking estrogen and all these things. They left that completely out, which I thought was great. So knowing your numbers, you got to know, it's all about the numbers on paper and then integrating it with how you feel. Sexually binding globulin with testosterone, total and free, you don't need to look at the sexually binding globulin once you're on TRT, because when you see the disparity between the total and the free, you know you could eyeball where your sexually binding globulin is going to be. Because again, like I said in the beginning of this video, you're going to see a disparity, and then you can just look at the free testosterone at peak or nadir dosing that we do, that trough, to just get an idea for what is your testosterone levels. Again, the total is basically useless. Greg, I know you know that. So what next? Using additional drugs. I know that Greg was asking the question, and I think he wanted to hear more about Masteron, Anavar, daily dosing, low doses, cycles, training days only, Decadurable and these things. And Derek definitely stayed away from that because he just thinks it's not going to be good using it regularly, which is kudos to him because we know guys do it, but again, it's going to affect your HDL, your blood pressure, the endothelial lining, the heart, the prostate, and it's just like, what medical issues do you have that you could worsen? So with that in closing, those guys did a great job. I think it's going to be a great added video right here that I can give. Their perspective is going to be, my input is know your medical information, do it history and physical, really get it done, know your medical problems that you're looking at, your family history for heart disease, your blood pressure, your cholesterol, glycemic issues like your fasting, glucose, hemoglobin A1C, again, the red blood cells, CBC, hemoglobin hematocrit, and the iron studies, really understanding that relationship, because almost every man that's on testosterone is going to have an increase in red blood cells. It's called androgen-induced erythrocytosis, but does it lead to polycythemia, many red blood cells, and most importantly, does it lead to a medical complication like a blood clot, a DVT, pulmonary embolism, heart attacks and strokes, okay? Headaches, blurry vision, all this stuff. So this is what you have to look at. And then of course the prostate. So get the history and physical, guys. Get a calcium score. I say it over and over and over, right? Get the calcium score. Understand your baseline if you have any plaque in the artery, okay, to start with. Get an echocardiogram. It'd be very interesting. Greg has a history of using steroids. Is Greg's left ventricle a little bit enlarged? Is it left ventricular hypertrophy that is slightly enlarged? And do you have a diastolic dysfunction going on already? Not to mention your ejection fraction is a little bit low or more than a little bit low, and that's systolic heart failure coming in. So the PSA, you got to look at your PSA, get a digital rectal examination from a urologist, because those are the best hands and finger to identify a lesion or an issue in the prostate. So next, you could integrate medicines. You could integrate medicines for blood pressure, ACE inhibitors, ARBs, bistolic. I talk about this stuff all the time on my app. Lipid issues, not just statins, but there's PCSK9 drugs. These drugs are now, I'm talking about them, it's ethical for men. There's Vascepa, which is an incredible medication. You have to have all this put together by a physician, obviously, but you, as you men, are taking charge of your own health, putting all this stuff together, especially for you, Greg and Derek, it's going to be so important because it's very complicated and it's got to be fingerprint oriented, man per man. That's it, guys. Let's get a lot of comments on this. Kudos to Greg and Derek for doing this and leaving opportunity for me to put in my medical 2 cents. Thank you, guys. Hope this helps people stay strong and healthy.